Hello everyone, my name is Leila Taché and I'm a third-year medical student. Today, we present to you an interesting case of an atypical presentation of tuberculosis known as a caseating scrofula. The term scrofula is derived from a Latin word and is used to describe tuberculous cervical lymphadenitis, an extrapulmonary manifestation of tuberculosis located in the neck. The term, once referred to as the king's evil, originates in ancient European history where the disease was thought to be cured by the king's royal touch. We present the case of a 32-year-old African-American female with a past medical history of gestational hypertension that presented to the ED due to progressively worsening discomfort and pain from a slowly enlarging right-sided neck mass that had been present for several months. The patient had a prior admission in June of 2020, where she presented with a smaller size neck mass and similar symptomatology. During this admission, a CT scan of the neck mass was concerning for lymphadenopathy with cystic versus necrotic components, a left apical lung nodule, and a right upper peribronchial opacity. A chest X-ray showed a focal, irregular right upper lobe opacity. Upon further questioning, the patient recalled having been exposed to tuberculosis as a child and undergoing treatment for 1 week. Due to high clinical suspicion for tuberculosis, a quantiferon test was ordered and returned positive. AFB sputum cultures were ordered as well, however, the patient was unable to produce sputum. An outpatient biopsy was scheduled, but was never performed as the patient was lost to follow-up. When the patient returned to the ED in February of 2021, she was found to be hypokalemic and hypertensive, and the neck mass had increased in size and was now associated with pain that worsened with movement. She denied systemic symptoms, including fevers, chills, night sweats, and weight loss. A repeat CT scan of the neck was performed. Figures 1A and 1B on the poster show us her scans, which depict a hypoattenuating and centrally necrotic lymph node mass, now measuring 4.2 by 7.4 centimeters in size. CT scans of the chest shown in figures 2A through 2F show multiple cavitary lesions throughout both lungs that were newly seen, as well as lesions seen in previous scans that had since grown in size. A quantiferon test ordered during this admission was negative. However, 2 out of 3 AFB sputum cultures returned positive for Mycobacterium tuberculosis complex. Pathology results of a fine needle biopsy of the neck mass showed caseating granulomatous inflammation. The patient was found to be having an active TB infection with tuberculous cervical lymphadenitis, known as a scrofula. The patient was started on RIPE therapy with B6 supplementation and complied with the Illinois Department of Health for continued monitoring. Following a 9-month treatment course, the patient's neck mass had decreased to less than 1 centimeter in size. It is important to note here that although the patient had a negative quantiferon test, she was still having an active TB infection. It is also important to note that she did not present with typical symptoms of tuberculosis such as cough, fevers, chills, weight loss, or night sweats. A scrofula typically presents, as it did in this patient, as a unilateral mass in the neck without the commonly seen systemic symptoms of tuberculosis. These types of head and neck masses only account for approximately 10% of TB cases and can be easily missed due to their atypical presentation. Early identification of these undifferentiated masses is highly important, as delay in diagnosing and treatment can result in long-term or fatal complications. This case exemplifies the importance of adequate testing through multiple modalities and scheduling proper follow-up if clinicians have a high suspicion of tuberculosis despite lack of their typical symptomatology. Thank you for your time, and I hope this presentation was informative.